Dan is a semi-professional footballer. Here he is performing a barbell back squat. Here we can see Dan is unable to break parallel. Furthermore, there is a lack of dorsiflexion, with the tibia and fibula failing to competently move anteriorly over the toes without the heels starting to come off the floor. From frontal and rear view, pronation can be seen. This is most likely to compensate for more dorsiflexion. Furthermore, to again compensate, Dan's foot alignment is angled outwards. Going back to Dan's inability to break parallel when regarding his lack of hip mobility with external rotation, we can see to compensate for the compressive shearing load onto the thoracic, lumbar and sacrum, Dan maintains an upright trunk position which subsequently avoids hip flexion. Firstly, to assess hip flexion, I have Dan perform a pole squat, testing hip-back dissociation as well as restricting dorsiflexion. In this position, it is clear that Dan achieves greater hip flexion, thus showing mobility at the hip joint is not an issue. I reiterate this here again, where Dan is performing a bodyweight squat with heels raised to artificially imitate dorsiflexion, with the tibia and fibula freely able to move over the toes. Again, Dan is seen to achieve greater hip flexion than is needed to break parallel in the kinematics of the barbell back squat. From these assessments, it is suggested that the underlying issue is at the ankles, with a lack of dorsiflexion. Using a knee-to-wall test to justify, we can see Dan achieves only 3 centimetres with his left until his heel raises off the floor, and 4 centimetres on the right. Given normative data from current literature, Dan's distances display stiffness in the ankle. We can postulate 3 possible causes for lack of dorsiflexion exhibited from Dan. Firstly, is Dan's myofascial meridians, more specifically the superficial back line, is tight from the plantar fascia, gastrocnemius, soleus, hamstrings and glutes. Performing self-myofascial release is an appropriate solution to combat this possible case. Secondly, is a lack of mobility in the ankle joint. Potentially Dan's ability for the talus to glide through the mortise is compromised as the tibia and fibula move anteriorly toward the foot. The top of the talar dome may come into contact with the mortise. To help correct this problem, I have Dan here performing self-mobilization through banded distraction, placing the band at the bottom of the ankle, creating tension by moving further away from his anchor. From here, Dan drives and bends his knee over the front of his foot into dorsiflexion. As the tibia and fibula move anteriorly over the talus, the band pulls the talus back, assisting in its glide into the mortise. Lastly is strength, which ties into Dan's apparent tightness in his posterior chain, which is possibly causing the slight heel raise or forefoot loading to compensate for his apparent lack of dorsiflexion. But you could rationalise that Dan's background of football displays a typical quad-hamstring ratio imbalance, with the quadriceps being more dominant, thus compensating in the eccentric phase of the back squat. Now, with regards to Dan's pronation, I rationale that due to an increase in tibial internal rotation, there's poor proximal control. Hip adductors, so the glutes and the TFL, are inhibited or weak in an eccentric capacity. Therefore, as you can observe, you get knee valgus. However, it is also argued that because of this proximal weakness, these structures are inhibited to assist with the lower extremity load response, placing more stress to supporting foot structures, leading, consequently, to Dan's poor pronation control. So in summary, yes, pronation causes tibial internal rotation and knee valgus, as well as creating a greater Q angle at the knee, but this may be caused by the eccentric capabilities of the hip adductors to control the adduction forces of movements of the hip, thus showing a lack in his strength capacity. To combat his lack of strength capacity, I have Dan here perform a hip hitch and eccentric sideline clams for glutes and adductor strength, as well as a solus eccentric calf raise. In support of Dan's capacity issue in regards to his posterior chain strength capacity and mobility capacity, I am here perform a Romanian deadlift. Supporting the findings from our previous assessments, hip flexion is not an issue, but instead it is that superficial backline. Here I have Simon perform a straight-legged raise, which supports this notion. Neil is a competitive golfer. Here we have him perform a barbell back squat. As you can see from the lateral view, he competently breaks parallel as well as maintaining a thoracic extension with an upright trunk position. However, as he moves further down into the descent, you can see lumbar flexion. When focusing distally from Neil's hips, it's clear to see his heels come away from the floor, thus showing the calcaneus is being raised and producing force through his forefoot. Neil performed all three assessments that Dan had performed, that being the assisted squat or pole squat and the heel raised squat artificially imitating dorsiflexion. From here, it is clear to see that his hip flexion with external rotation is not an issue, nor is dorsiflexion, with Neil comfortably achieving over 10 centimeters in his right and left feet. So there are two things to address. Firstly, the forefoot weight bearing, and secondly, the lumbar flexion. I asked Neil to perform a regressive movement, the dumbbell front squat. This was to test if balance is the possible causation for Neil's forefoot loading, with his projection of their centre of mass over the base of their support being off. By shifting the weight anteriorly, acting as a counterweight, this caused a mid-weight foot-bearing position. As you can see, the athlete is able to produce dorsiflexion without becoming unstable. However, he does show excessive lumbar flexion, with his pelvis rotating posteriorly as he moves past parallel. With addressing the lumbar flexion, this can be caused by a lack of dorsiflexion or hip mobility. However, as stated earlier, assessments show that this is not the case. Again, hamstrings have been suggested as a cause, with the notion as the lifter descends, the hamstrings are stretched, staying further to produce force through the attachment of the pelvis, pulling the pelvis into posterior tilt. Yet this does not make anatomical sense. Furthermore, it is clear to see Neil can avoid excessive lumbar flexion by just achieving parallel in the squat, thus showing it is an apparent lack of familiarity with the movement, not a capacity issue, that causes the quote-unquote butt wink, thus supporting that Neil has a lack of motor control in the barbell back squat. Carl is a semi-professional rugby player. Here I have him perform a single leg Romanian deadlift. From this lateral view, we can see Carl fails to keep his hips extended on the rear leg, which can be caused by lack of hamstring flexibility or balance, caused by lack of motor control in the posterior. In the frontal view, you can observe slight pronation of the foot. Regarding the pronation of the foot, it appears to have little effect on the movement, with little to no knee Q angling or valgus of the knee. This leads us to looking at the hamstring strength and length, capacities being the cause of the non-optimal execution of the movement. However, having Carl perform a straight leg raise and seated knee extension shows that hamstring length is not a concern, with more than enough range for the movement. I have Carl perform a single leg squat to display unilateral competency. From here, despite slight valgus, the movement shows that Carl has the strength capacity required to weight bear unilaterally. Again, with competency in capacities of strength and mobility, it is rational to suggest that the lack of movement patterning of the skill is the main cause for Carl's inability to perform. Using regressions such as foam roll assisted RDL, landmine RDL, or even a kneeling RDL will be a great way to practice positioning and patterning, essential when developing a skill.